So wearing contact lenses is
the most dangerous part, the most dangerous factor, the most dangerous issues. Did you read any complication related to the contact lens? So those that they are using the contact lens chronically.
Meet Dr. Safwan Al Bayati.
He is consultant ophthalmologist and he is medical director of New Vision Eye Centre, Dubai.
Had his FRCS in ophthalmology from the Royal College of Physicians and Surgeons of Glasgow in UK.
Dr. Safwan Al Bayati is a consultant in refractive.
He is expert in cataract extraction by the latest technology, by phaco, with the use of premium lens.
If you can imagine that our life now, we are using the device from morning till evening, more than 20 hours. By the way, this is not the end of the story.
welcome, Dr. Safwan.
Most welcome.
Thank you very much for
So
being
safe.
on my podcast for the very first time, and hopefully not the last time. We are going to talk about something which is very, very interesting, and it's a rising topic, which is refractive surgery. So many people from my network, people that I meet, clients, friends, relatives, ask me about refractive surgery, knowing that I used to sell these machines just for past 20 years now. And as if I know more, but there are certain things that I know, but of course, you know much better. At what age should a person be eligible to do the refractive correction? And what is refractive surgery?
Well, thank you, Saif, for inviting me for this broadcast. I'm so excited to do this interview. Well, actually, there is an agreement that says that the 18 years old is a cut. And why we have this agreement? That's all the study shows that the changes in refractive error beyond 18, it will be more slower. Definitely depend on the refractive degree that the patient have. But if you will compare the age above 18, more than 18, and below 18, you will see that the acceleration of changes below 18 is more. That's why we have an agreement that 18 is the legal age that we need to start with. In spite of that, the degree is very important. So those that they have more than 3 diopter in minus and myop, they might have changes or they might have another changes. That's why we, as a refractive surgeon, we are considering this part and we are putting it in our consideration when we are dealing with this patient. That's those that they have more than 3 diopters total spherical equivalent to be and dealt with different way when we are dealing with them, or they need to do it before or at 18.
So not before 18.
Well, sometimes we are in doing when we have patients that they are chronically using the contact lens and they have problems with the contact lens and they cannot use glasses. Yes, I do agree, because that's more safe. As you know, safe. The most dangerous part, the most dangerous factor, the most dangerous issues on a patient that he need to do a refractive surgery is the contact lens.
So wearing contact lenses is
Contact
prohibited.
lens prohibited. Contact lens will deteriorate the cornea and prevent us sometimes from doing the refractive surgery. So contact lens is very dangerous to the person that he need to do a refractive surgery.
Okay.
And you need to ask me why.
Why?
Unfortunately, those that they are wearing contact lens, they are not aware about the side effect. They are not asking. Like a lady's coming to me wearing contact lens, please prescribe a contact lens for me. And please don't discuss anything related to the refractive surgery. I am afraid because there is a lot of complication. I said, did you read about the complication that came to the refractive surgery? She said, yes, I read a lot. Did you read any complication related to the contact lens that you've been using it for 10 years? Well, actually, no. Apart from that, I know that there is a dry eye. Okay. So she don't know that there is a severe dry eye, and most of the population that chronically using the devices, now they have a dry eye.
Yeah.
So adding factor, that's one of the issues, and this is not a simple issue. Second is that the contact lens reducing the thickness of the cornea. So those that they are using the contact lens chronically, their cornea thickness, which is very important for any refractive surgeon, reduced because of the ischemia. They don't know that this contact lens create an ischemic changes in the stroma of the cornea, in the center core of the cornea. Why? Because it reduces the oxygen intake of the cornea, where it depends on the aqueous of the tear and the aqueous inside the eye. Now, aqueous of the tear, it gives the most of the oxygen and the glucose to the cornea, and that prevented. And third, infection, corneal abrasion, scratch of the cornea, and one of the serious corneal ulcer is the acanthamoeba, where we most of the time we end up with a corneal opacity and corneal whitening, and we end up in the best case scenario that we need to do laser. In the best, I'm saying in the best case scenario, maybe 20% of them. So 80% they end up with what? With a corneal graft. So it's a serious. And when I'm asking them, please read, no, I don't need to read. I cannot withstand without contact lens. So you can see, there is a lot of conflict here that they used to it. And by the way, the inconvenient for or when the patient start to have irritation and that will be accumulative. So it will not start in the first year, but it will be end up maybe after 10 or 15 years. So I have patients that they came to me with a corneal ulcer after 15. One lady that she came with corneal acanthamoeba that she swim with a contact lens. And by the way, most of them, they are sleeping with a contact lens and they are swimming with a contact because they forget that they are wearing contact lens.
So this is
an added factor to the issue, because they are sleeping and they are going, and because they are not washing their face, unfortunately, and they forget that the contact lens is there. So here we have the problem, is that acanthamoeba as an amoeba can be in the soil, can be in the dust, can be in the water, can be in the swimming pool. So it's very risky.
Very risky.
Really, it's very risky.
So can we say in summary, like wearing contact lenses is not ideal? The ideal thing to do is either wear the spectacles, the glasses, or operate and go do the refractive surgery.
So the safest till now, agreed by all the surgeons of the world, is the glasses. But if the patient can withstand it. Now, if the patient cannot withstand the glasses, what we'll do? Here is the refractive surgery. So when we are talking about refractive surgery, all of us, we have a general information about refractive surgery. And we have second information coming from the advertising element, from the social media.
True.
And the third, the one that he start to search and ask. That's why most of the centers now, they are doing a free consultation. So they can ask. They can ask and they can search. Now, why I'm saying that? Because they might have a lot of advertisements saying that this is the best and this is the best. That's why let us start from the beginning. Now, all of us agree that the laser or PRK on the cornea is one of the oldest, one of the first refractive surgery that started. Now, some of them, they are saying in the mid of 80, others, they are saying in the in 90, but it's the first one. It's by concept is the laser that applied on the cornea. And this laser applied on the cornea, it was very simple, basic, primitive. It didn't have any tracking system to the cornea, to the eye, and you know that the eye is moving when the patient is laid down. So when on supine position, this is the main problem now. In supine position, the eye in a certain position, and then when the patient's sleeping, the eye will rotate intorsionally, means that to inside or to outside,
Yeah,
and that's variable.
these things, these details, me and you will understand, but
Exactly.
unfortunately,
So
the
that's why
people,
I'm
yeah,
telling them.
mm,
So when we are hearing that, well, we have this laser options with this prices very low, means that it's a very basic.
yeah.
It
So
doesn't have this technology
accuracy, it doesn't have the
and
accuracy
the
and the safety
accuracy and the
also.
safety.
Yeah,
Anyway, now the laser, it's still available, but in a highly advanced technology. Now, what's added to that? First of all, is the tracking system that start XY and then torsional track system. And that definitely, it has two part, the static and the dynamic. Means that when the machine start, it will take the registration of the eye, and this is very important, as you know, very important, because otherwise we will not be able to treat the astigmatism. That someone of our colleague will say, no, we are taking the gross marking to the cornea, but I think that we reach to a degree that we don't need to do such a thing. We need our machine to do it because this is more accurate.
yeah,
So registration as a static is very important here.
yeah. So I can say it in other words, maybe that people and patients can understand it, because this is very deep terminologies that you
Yeah.
use. Is that the importance of the diagnosis of the eye sitting
Yeah,
position and
exactly.
lying position is totally different.
Exactly.
So in order to shoot the laser in a very accurate way,
Yeah.
there are different machines out there. There are speeds of how accurate that the machine can register the eye sitting, and then
Yes.
the difference
Lay down.
of it laying down
Exactly.
to match and track the eye while the operation is happening. There's a slight movement which can cause very severe and dangerous corrections, induced corrections.
Induced
Yeah.
things that we
So
don't have it. The
exactly.
machine will induce it.
So can we translate these changes or effects as if it is like halos that people see at night,
Yeah.
or what is it exactly?
The issues is that with the simple sphere, sometimes it might not affect.
Mm.
But when we are talking about customized,
Yeah.
or other, they have different term for customization, contura, or others they have I don't know, there's a lot of names for
Yeah.
customization. The track system, registration and track system is very, very important. And when we are adding the customization, means that we are treating the minute irregularity in the cornea. So the cornea have different issues when we are treating. We are treating the sphere, the which translate the difference in the axial length, and we are treating the cylinder, which reflect the difference in the irregularity of the cornea. That irregularity is the gross, like when we are saying this patient having -2 sphere and -3 cylinder or -1.5 cylinder. But when we are talking about high order abrasions, or when we are talking about minute irregularity, which is translated from the elevation map. Now, elevation map translated and incorporated into something that translates this minute irregularity. What's this minute irregularity can create? It can create some quality difference in the vision. So someone that he's seeing 6.6 as an acuity, but he's not happy, as if that he's looking to the photo of 4 megapixel.
Yeah.
And someone else will see it through 40 or 50 megapixel.
Okay.
So this is the difference in quality of vision. So there is acuity and there is quality.
Yeah.
Now, in customization, it's supposed to go to a high quality of vision. But all these, to tackle that point, it need a track system.
Yeah.
Without a track system, what we'll have, we will go to treat point which is not there. So any machine, in any explanation, saying that, well, we have a 4 dot neurologically, so the patient can see to the 4 dot. I don't think so that it's true. So without static and dynamic track system, there is poor customization
Poor end results for the patient.
for
So
sure.
it's not like these cameras that we have high-end
Eh,
pixels. So
no.
you will be seeing something like an old Nokia
So when they are
phone.
saying HD,
Yeah.
I'm asking what's HD?
Yeah. We're talking 4K here.
Yeah. see
Yeah.
what we are talking here.
Yeah.
We cross this line.
Yeah.
Crossing the line means that we are crossing the edge of this technology.
Yeah.
When we cross the edge of the technology means that I can show you the result of the patient that he passed and he cannot reach 6.9 or he cannot reach the optimum vision 2020 and then he reached it.
Yeah.
That's the technology. That's the edges of the technology. By the way, this is not the end of the story. The surgeon should preserve the low order revision. It means that -2, -2, he should end up with plus minus 0.25. That's the result. Otherwise, no. So if patient treated by customized and end up with plus 0.75 plus, this is not a good result. The
Yeah.
patient will not will suffer again.
So in summary, you need the right technology with the right calculations, which definitely comes from the right doctor to
Exactly.
choose both. So you cannot say it's just the machine,
No,
and you cannot say it's just the doctor.
exactly.
It has to
That's
be both.
absolutely both.
Yes.
Both, and the experience in incorporating between both.
Yeah.
So when returning back to the laser, now the laser is in highest technology.
Yeah.
Now what's the else? We have the transepithelial. Now when we are doing the laser, we are not removing the epithelium.
Yeah.
And I think that in the market there's two type of machine, our machine and the other machine.
Yeah.
There is another machine that they have.
I remember the machine that I used to sell has the now transepithelial
Exactly.
treatment.
Now
Yes.
we are talking about now.
Yeah.
And I'm using transepithelial for the last 15 years.
Yeah.
And still that technology, that technique for someone, I respect him a lot. He's the one that he discovered, Mr. Samuel. He's the one. And all the favor related to him because he's the one that created. Anyway, that technique will not give the patient the burden of using the alcohol 70% on the cornea and removing the epithelium mechanically, and then irregularity of the periphery, and then shooting the laser on.
Yeah.
Shooting the laser on what? On a surface that it's not been taken by the topography, because topography take the surface with the epithelium. And with all remodeling of the epithelium, when you remove it, what you will do? You will shoot on a new surface, as if that I'm taking picture for safe, and then removing the face of safe, and then adding something on the flush. Different.
Yeah.
Totally different. The topography will be different.
Okay.
So now all of the companies, they merged and they realize the importance of the transepithelial laser on the epithelium. And when the patients start to be knowledgeable and asking the doctor, he's shocked. He said, okay, no, sometimes we don't have. Sometimes some centers, they don't have this technology.
Yeah.
See?
So we are here to educate the patients and push other doctors to upgrade their systems and to
Exactly.
reach up to the level of talking this new equipment. So transepithelial, in simple words, because I've known this from my side. And again, I'm trying to simplify here the terminology for the patients to understand what we're talking about. I know, so that's why I cannot speak.
Exactly.
So usually the technology of the refractive
PRK,
surgery is
or laser.
removing a small thin layer from the cornea, which is the
cover,
crystal or the cover of the
just
eye.
like a derm of the skin.
Exactly. To remove a small thing, which is we used to use before keratoconus. The machine, the Moria, or
but here we are talking about epithelium.
Yeah, so we remove the first layer, and then the laser has been shot.
Yeah, on the base.
On the base, and then cover back again.
No,
Now,
that's
the
the
old technique.
LASIK.
Yes,
No, but in the laser, no, we are removing the epithelium and remove it. That's all.
totally. Yes.
And
No, I'm
then
just
apply
going
the
back.
laser,
Yeah.
and then we are putting a bandage contact lens.
Yes.
Now we are not no more removing it mechanically,
Yes.
since long back, definitely. But now it start to be known because other machine also they are doing it. I don't know whether they are practicing it because now they have it in their machine.
Yeah.
I don't know whether they are practicing it or not. What we are doing, we don't have now. I didn't do a PRK per se for the last maybe 10 years.
So PRK is just removing,
Just remove mechanically the epithelium and then doing the laser
and then putting,
and then bandage contact. But the trans PRK, no,
you don't touch the surface.
I'm not touch the surface. The
so
laser,
this is the latest technology.
Yes. The laser will apply on it and removing the epithelium according to the topography that's been taken, which match the match between the epithelium and the topography, because epithelium shows some covering, any irregularity, it remodel, it's thinning at that side. So the laser will take care about that.
Let's call it fine-tuning to
Fine-tuning,
reach to the end result
Exactly.
of how you want the patient to see.
Exactly. So now our tomography now measuring even the thickness of the cornea epithelium, and it's took that thickness. That's the more latest side. So the accuracy is coming from this point. That's if you are still talking about the laser. Now, is there any indication for the laser? What's the frequency that we are using laser now? Well, it's not frequent, actually. It's not frequent because the recovery time. The recovery time, Safe, it's longer. And post-op, there is some difficulties, inconvenient time because of the watery burning sensation of the eye and the watery coming from the eye. So that definitely will annoying the patient for the first 3 days or 4 days until the full epithelium will recover. In spite of that, the trans PRK is more accelerated, is more less painful and more shorter time for the recovery.
Okay.
Because the regular edge of the periphery, so the cells will run to the center in a faster and in even way.
Okay, that's nice. So this is one of the advantages of the trans PRK, is to help the speed in recovery and less pain.
Exactly.
Yeah.
So the topography showing that some patients or some of the candidates that they are coming asking for the refractive surgery, that their cornea is thin or weak, or there is some weakness. By screening, we are using 3 types of screening. We are using the latest MS39 topography, which is the latest technology, have screening, and we are using the Pentacam screening, which is Bell and Ambrosio, and others. Those screening, they are checking if the cornea is compatible, or this person, a cornea of this person, eligible for this type of refractive surgery. Now, recently, we add the Corvus, a biomechanical assessment of the cornea. The biomechanical assessment, it assesses the strength of the cornea. So it gives you measures. These measures, I'm showing it to the patient because it's a traffic light measure. So it's coded by colors. And these colors shows the green and yellow and red. So I can show to the patient why I decide to go to the laser or other. I'm not happy with the LASIK, or I don't need to do LASIK for him, or he's not eligible for a LASIK. Now we will come to it. So from this point of view, sometimes patients, they have to do it. They have to do it. We don't have any other option. Others, no, it's their choice. So when their choice, I'm explaining to them that you need to be at home at least in the first 3-4 days. And then after that, the vision will come up gradually, and you might need from 5 to 10 days for the recovery. So they need to adjust their jobs, their duty, their and
This is
anything
if they
related.
choose.
If they choose that, or we choose forcibly because he is eligible only for the PRK,
Okay.
because it's there is no flap in the PRK.
Yeah.
And because there's no flap in the PRK, like in the LASIK, which the flap is the slice in the cornea that we are creating it either mechanically or by laser. And that slice will reduce the biomechanics of the cornea more. So from this point of view, sometimes we need to do only
PRK
laser
or laser.
because the cornea is weak. Why? Because they are chronic users of the contact lens, because they are rubbing their eyes a lot, because they are using phone for continuously without blinking, without using the artificial tear, because they have a severe dry eye, because all these we are assessing it now. No refractive surgery without assessing the tear film stability. No refractive surgery without assessing the condition of the cornea. And we can see in details in more than one machine. You can see we are not depending on one machine in assessing the eligibility of this patient to the any refractive surgery. So here, if the patient eligible for the others, then we will go to discuss the other option, which is LASIK. Now, as you know, that the LASIK is the most famous. The most famous means that the less pain, the shorter the recovery time. But we have cut of the cornea. So patients, they are coming. Is that one that you are talking about? Is there is a cut in the cornea? Just to shortening the or simplifying the issues. Then we are saying yes, in LASIK there is a cut. And that cut, we can do it mechanically using a microkeratome, where it's a microkeratome. It's a machine having a blade.
Yeah.
So when they are hearing blade, oh, blade, yeah, it's not the blade that we are cutting tomato. No, it's a special blade with high oscillation. And this oscillation, you cannot see the blade. With it, when the oscillation started, you cannot see the blade.
Yeah.
Now, is that the one that, is the one that they start with, the first? Definitely, now there is a high advances in the microkeratome, in the site of the microkeratome, in. So there is high technology, but still there is a blade and there is a complication still.
Sure.
When we are saying, well, what's the percentage of the complication? Because our patients, they like the percentage. I need exactly what's the percentage. Well, there is maybe 2% or less now. In my practice, I don't have this percentage. Actually, I'm very low now doing the LASIK. Here, why?
Yeah.
When we are saying mechanical, we have the alternative. We have the laser.
The femtosecond.
The femto LASIK, where the flap that we are talking about is done by laser.
By laser, no need for the blade.
No need for the blade.
Which we're talking about, this is a second machine.
Exactly.
Yeah.
So when we are talking about the LASIK, here there's two categories, ultra LASIK, or what we are talking about now, ultra LASIK is the only terminology. The mechanical LASIK and the femto LASIK, because the femto machine is creating the flap. Now that flap in the femto machine, definitely more safe. We can say 100%. In creating the flap, if we are talking about safety from the creating the flap. But still we are creating flap. Still we are interfering with the biomechanics of the cornea. Still we are creating more dry eye. Why? Because when we are cutting the flap, we are cutting the corneal nerves. Corneal nerves, it's 550 or sometimes 570. So the corneal nerves only in the first 140 or 150
of the depth of the cornea.
Of the depth of the cornea. So the superficial part of the cornea, having the most of the corneal nerves.
Yes.
What we are doing, we are coming and cutting it.
Yeah. There's no other way.
There's no other way.
Yes.
So, no, there is another way.
Other technologies.
Yeah, there is another way.
But
actually, but in the ultra LASIK or in the LASIK, sorry, I don't need to use I don't like to use the terminology. In the mechanical laser or mechanical LASIK or femtoLASIK, we need to cut this part.
Yes.
So this part is important because those corneal nerves, the end of it reaching the corneal surface, and that it's very sensitive to any dry patch that can appear after that. And that stimulate by afferents, يعني send a message to the brain to create the blinking and to secrete the secretion of the tear. So this will be blocked. If you can imagine that our life now, with the modern life that we are using the device from morning till evening, this process is already being quickened sometimes for those chronic users that they are using um, computer and the phone for more than 10 hours or 15 hours. Maybe I'm so يعني poor in assessing the times.
Yes.
More than 20 hours sometimes. I have patient with the 12 or 13 years, more than 20 hours they are using.
Yeah, true.
They have already dry eye. So when we are inducing this flap, we are inducing more dry eye. So we'll end up with a very dry cornea, irritating, and the patient is not happy with the vision because the epithelium is hyperplastic undergo hyperplastic changes. And if you will assess by the corneal epithelial map, you will see a red mapping on the corneal thickness, which is coming from the hyperplasia of the epithelium. It can reach 100 while its original thickness is 50 because of these. Now, we are not doing it. No, we are doing it. So we are carefully assessing the patient here. Carefully. I mean carefully, that he need to pass all the screening and it's positive. It's safe. Means that he is eligible. So I'm doing I'm depending on the MS39, which has its own screening, and Pentacam and its own screening, 2 screening in Pentacam, and Corvus 3. I'm doing it. 3 of them should be safe, should be say that this is eligible. Then I will go to the ultra laser. Sorry, the second things that I will assess the tear film stability, breakup time, Shermer, all the assessment of the dry eye. You need to pass. Otherwise, I will not do laser. Or I will start treatment.
Yeah.
Stop contact first. First, stop contact. No, I cannot. Okay, we cannot do the surgery. We need to stop contact.
So it's a must that they have to leave the contact lenses before any refractive surgery.
That's for sure. At least 10 days. At least. Yani sometimes when we are seeing that the patient having good tear film stability and he is not a dry eye patient, like he's using it only for a few hours and he's not chronic users for the phone, we can allow him for 3 days or 5 days before the surgery. But those with a dry eye, no. How we will cure the dry eye with this kind of contact lens that he's sleeping with it or she's sleeping with it? So from this point of view, we are assessing and preparing this patient in a very careful way. That's why I'm seeing some patients coming after the surgery that done here and here and cure them, because we have a lot of issues. Dry eye first, apart from the undercorrection or overcorrection or induced astigmatism and so on. So the first issues is that to let them stop any medication that interfere with the tearing, especially the young chaps. Now they are using some medications for the acne, and for even they don't have acne, they are using because their colleague, they used it. So they are so excited to use these medications. These interfere with the tearing and it interfere with the normal lacrimation. So I stop it and stop the contact, and they should blink 10 times every 30 minutes using the contact, using the devices, phone or the computer. 10 times every 30 minutes. and they should use the proper artificial tear. It's not any artificial tear.
Mm.
Proper artificial tears that cover the three material of the tear film component. Here we are talking about the mucin and the aqueous and the lipid, because they will have disturbance of mostly the mucin and the lipid. So they will have dry eye from, even if they will use some artificial tear that they don't have this component.
Okay.
So everything should be proper. That's why now we have less complication with the LASIK, because we are highly selective patient to do LASIK if they need.
Okay, interesting.
Yeah.
So,
If not, and he is eligible, then we will go to the recent or last option, which is the SMILE.
Mm.
Now, SMILE is a terminology came from one company,
true.
and they were restricted to them until 2017. It's a lenticular extraction. This technology is not depending on the previous technology that we are evaporating the tissue. What's the concept of the refractive is that we are using the laser to evaporate tissue removal by evaporation. That's why all our patients, they experience a smelling of barbecue smell.
Yeah.
Here, no. Here we are assessing the cornea, and we are going deeper than the 130.
So avoiding the nerve
So
layer.
avoiding the nerve layer and creating a lenticule. This lenticule is equal to the tissue that should be removed by evaporation. Now, this technology appeared in 2011, starting from 2010 in the trade, but it was primitive, simple. No registration, no centration. When we are talking about the lenticule, the shape of the lenticule, the periphery shape of the lenticule, the depth of this lenticule, all it was primitive. Not dealing with the astigmatism because there is no registration.
Yeah.
So it was
very basic.
Very basic. Dealing with those that they have, let us say, for example, as one of my colleagues said that it's only for the high myope. Well, it's not actually.
Mm.
It's for all.
That's actually what I heard. That SMILE technology is.
See, that's why I'm tackling the point.
It's very precise for certain category of patients,
and that's not totally not true.
Okay.
You can imagine that now I'm treating minus 0.5.
Mm.
Is it fine? Sometimes we are by LASIK, we are not treating. We are treating it now. Why? Because the technology is totally different. After 2017, all the companies start their research for their machine, which was restricted to one company.
Yeah.
Here, from this point of view, they start the first issues that it was lack in that the first machine, the primitive. Registration, centration, track system.
Yeah.
And that's the main important issues, and improving the lenticule shape and the periphery to reduce the high order abrasions or spherical abrasion after. Means that any changes of the cornea after the refractive surgery. And that's what's happened. So I was ready to have the machine in 2019, and we prepare everything, and we were celebrating, and then we entered to COVID, and that definitely delay the trading of this machine till 2000. I think that 20 started, but unfortunately till because the economical issues that was preventing us.
Yeah.
So 21, 22, beginning of 22, we had the machine and we start. And it was one of the first machine in the JCC that has a registration.
Okay.
So now the best topography in the world, which is the MS39, I don't think so that someone will, or others, they have any doubt about this machine now.
Okay.
MS-39 is a topography depending on a certain technology that it can read the cornea from the epithelium, the first epithelial layer, till the end in a very accurate way. Ray tracing, certain optical technology that makes this machine is the best reading, having the best information. From this machine that will track and take the registration of the eye, pupil, and the limbal, send it, we will send the information to the machine, to our smile machine. This is our smart smile machine because we have this a trademark.
So yeah,
Now it's a
it became a smart smile.
smart smile machine. So when you are talking about smart smile machine, it should have a registration and should have centration. And now we are treating -5 cylinder. You can imagine. We were afraid when we were doing the smile in the past with -1 cylinder, and we are saying, well, we can treat, but maybe we will induce one because the patient rotate his eye. And then when we have this technology, we discover that how much the patient moving the eye, and how much the machine move with his eye in a way that get the accurate access of the astigmatism, in a way that applying on that side, very simple, very compatible interface, means that the cone that coming on the eye in a very non-painful way, and the size of it and the depth of it and the flattening of the side, it's compatible to all type of the cornea. Because when we are talking about -5 cylinder, we are talking about steep cornea. So this might not compatible. No, this is compatible for all. So we are not changing. We don't have two type of interface. We have one type of interface.
Interesting.
That's definitely very exciting.
This is the beauty of technology in ophthalmology world and the eye world, where companies see each other and take their minuses and make it more advanced. And I enjoyed this for many years.
You had it in the past. Now, what's the beauty of it is that it's improving in a very accelerated. Why? Because the patient needs it. Because the patient will have only 5 to 10 minutes. There is no cut. There's only a small incision through which we are removing the lenticule. I don't think so that you saw it, right? No, maybe in the.
I need to attend one surgery one time.
You need. Actually, you need. And the removal of this lenticule from this small slit, then that's it. So 2 hours the patient will be free. Is it free? Yeah. He can drive. He can do whatever. So for the female and male, they are coming to me. We can drive. Yes, you can drive. There is no flap that you are afraid that it will move. Or the second day, the patient coming with the flap moving and the edge of the flap is coming up.
Because you're not treating anything beyond the surface.
Exactly.
It's totally deep.
The cornea is not changed at the surface. Now, is that means that the biomechanical part of the cornea is better than the LASIK? 100%. We are approving it by Corvus. Some will say that, no, we have. No, we don't have.
So Corvus is another machine that measures the
biomechanics. So what we are doing, we are measuring the biomechanics before and after. And comparing between, because we are running a study, comparing between LASIK, laser, and smile. Still the laser is higher in the rigidity of the cornea post-op for each one diopter, because that's what we are dealing with. We are measuring the stiffness of the cornea reduction for each diopter treatment. Stiffness, cornea reduction, means that the stiffness of the cornea was 100. After treating 3 diopter, it should be, for example, 90. In LASIK, it will be 80. In laser, it will be 92 or 93. In smile, it's 90. So the smile is very near to the laser by reduction of the stiffness.
Stiffness.
And that definitely push us to go through and do. But this not mean that those patients that they have irregularity or um, first degree of keratoconic or the chain or the cornea having something called foam frost means that is the early changes of the cornea that might be progressed to the keratoconic is eligible for. No,
Yeah.
they are not eligible. Now, there is a lot of studies done and there is a lot of issues, but it's very promising, really.
Interesting. Yeah.
It's very promising because the recovery time is less than even 24 hours. And returning back to the normal life, because we are saying, yeah, in the LASIK, second day. Now, someone will say, Dr. Safwan, second day the patient is seeing and driving. I said, yes. But how about using the phone and computer? He will have a dryness for 3 months. What about what about the smile? Now, according to the degree, because if I will treat -9, 100% he will have a dry eye for 1 week or 2 weeks. This is because of the inflammation. It's not because we cut the nerve. It's because we are applying inflammation, and that inflammation affect the first layer.
Yeah.
So it need to be treated for 1 to 2 weeks. But -9,
Yeah.
1 to 2 weeks.
That's a different out of the
Comparing to -1,
Yeah.
and he has 3 months. So when we are seeing this variable in the sign and symptoms after the surgery, how the patient return back to their life, and when I'm asking them, please come, let us follow the case. Well, we don't have time. We are fine. Why we are coming?
Yeah.
I said we are running things to help others.
Sure.
So we need to do the corvus, or we need to do testing to see what's happened and where we are or how we treat. And believe me, I didn't have a result of 0 in all my always it's plus minus 0.25. Someone will say that, well, we have always. I would say, sorry, we can't. But in smile, yes, we have it now. 0 safe. You know what 0? I took a picture with one of my client. He has -6, -4, and now 0.
Wow.
So here, and he's very happy, and he's saying that, well, all my patients, all my colleagues, they are complaining, and I was using the glasses in thicker than the others, so that's why I told them, because they did other types,
Other
means
types,
that the LASIK.
Yes.
And when you are doing LASIK, usually we have a dry eye for a while of time.
Sure.
Any patient, he need to know that.
Yeah.
That's right, there is a difference in the prices, not too much, but there is a difference in the prices.
Of
But
course.
for sure, when I'm choosing a LASIK, for sure I need to know that I will have a dry eye.
Yeah. So there are, in summary, like right now, as you mentioned and this explained in a very beautiful, deep way, we have the laser, we have the LASIK, and we have the smile technology.
Yeah.
So patients who come to your clinic or any other clinic, they should be knowing the differences between
Exactly.
these, which you explain
Exactly.
to them. And definitely you will also choose according to their situation.
Eligibility.
Yes. So not everyone can come in and tell you, I want smile.
Exactly.
Or not anyone can come and tell you, I
Yeah.
want laser
Yeah,
or
that's,
LASIK.
that's a very good question, because still
Yeah.
the technology is not finished, because here we need to say that, well, hyperopia, because hyperopia is not included.
Yeah.
That's right. We have a very small contribution in our refractive surgery by hyperopia. Let us say, for example, less than 10%. Less than 10%. It's not till now for all machine active as a software. Now, yeah, it's coming in the pipeline. It came, but it's the software. It's not reached
Ready,
to the market. But let us say, for example, what is the most popular issues is the myopia, then myopic astigmatism, then mixed astigmatism. That all we have it now.
Yeah. So
which
those
is
are the majority of the
majority.
patients.
Those that the most complicated,
Yes.
plus minus.
Yes.
The plus minus is the most complicated. That all of us, we are very careful. We are doing very precise issues, and all the enhancement is in mixed astigmatism, not in the simple myopic.
Mm.
Simple myopic, and I will do enhancement. This means that there is something wrong in the machine, right?
Yeah.
I need to review the technology. I need to review the machine. I need to do a maintenance in the machine. I need, and I'm seeing simple minus 1.5, and then end up with a plus minus. Anyway, now apart from these issues, when we are covering the three major, the myopic astigmatism and mixed astigmatism in this machine, which will be very, very soon, then the simple hyperopia will be only a simple categories of those, which is less than 2%, because 10% mixed astigmatism, including the mixed astigmatism, plus minus. And when we are removing the mixed astigmatism, what remain is only a simple hyperopia, very rare.
Very rare, yes.
That they have only +2 or +3 or +4.
True.
Yeah, those very rare. Now those better to do a femtoLASIK, but it's coming in the pipeline.
Yeah.
We are preferring because of their refractive error. We prefer to do a femtoLASIK instead of the SMILE, but still it's coming.
It's coming as a technology.
As a technology in the SMILE, where personally, when I'm saying I'm very happy now, 80% of my practice is a SMILE.
Yeah.
80%.
Very nice.
So when you are comparing 80% now, 2024, we are ending 2024, and comparing it to 2014 and 2006 and 7 and 8, and it was only LASIK and laser.
Yeah. So totally.
Then 12 started to be femto, and 13, 14, 15 still femtoLASIK. It was the best. It was and still femtoLASIK is working, but that was the technology that we have. And the SMILE at that time, it was a primitive, and I can't use a primitive technology to treat my patient because I might induce an issue. Now, when someone will say that, well, still you have a problem with the under and over correction, I'd say no, we don't have. So how you are correcting it? Still we are doing SMILE to correct it. Why? Because we have centration and we have track system. We have a record for our parameter. That parameter, we will return it back. We will apply it on the same eye, and we will do the same, and we will correct. That's right. There is a modification in setting that we are doing, but still we are doing. In the past, we had two major important problem when we are doing the SMILE: suction loss during the surgery, that I need to cancel and go because I don't have centration. Because if I will go back, I will induce another site because the centration. Here, no, I will go back 10 minutes after the suction loss, and that's what I'm doing. Under correction, patient having under correction, yeah, we can do it easily by SMILE. Yeah, by SMILE. So that's the advances. That makes you practicing in a good way.
Yeah.
That's why you are asking yourself, why I'm not doing only SMILE? The patient is happy. There is no problem. The patient, they are traveling second day. They are doing everything. I don't have the problem of the LASIK flap. I don't have ingrowth epithelium. I don't have flipping. I don't have folding of the flap. And I don't have a crease of the flap, all the complication of the flap. I don't have it. Now we forget even how we were dealing with this stria of the flap. And the patients coming, that our patient, most of them, they are sleeping on the face in this way, in that way, in this way, which is all wrong.
Yeah.
But still, in SMILE, doesn't matter because he has the same eye.
Mhm.
The only issues is that we are changing the thickness.
A little bit in the bottom.
Yeah.
I have one question, doctor. Maybe we can end up this podcast by this question: Is what does Dr. Safwan see in the future or wish in the future of refractive surgery to happen from the companies out there?
Well, that question that always I'm asking my dearest Sam, the one that he's applicant director of the company that they are providing all these machines for me, and I'm the scientific senior scientific surgeons here in JCC. Uh, what's next? What's next? And he's asking me why you are in rush. I said I'm not in rush. My patient they are in rush.
Exactly.
My patient asking when they are coming, as you said, that hyperopic, and his cousin he was myopic, and I did for his cousin a smile, and then he's coming and he's hyperopic. Well, I don't know. I will be very embarrassed to say, well, see, till now hyperopic is not, and يعني, I'm not very convinced that hyperopia will be. So let us go to another technology that the femtolaser. That's what I'm pushing. But recently we will have the mixed astigmatism. And here, someone will say that, well, Dr. Safwan, you missed one important issue. That that small irregularity that we are able to do it when we are doing the LASIK, laser, femtolaser. Here we are not doing it. Well, yes, I do agree that those that they have a very high order abrasions, we are not able to do it. We need to do a femtolaser. Still, the technology is not coming, but it's coming. Prisbimax, LASIK for those that they are above 40s.
True.
And that's very important because till now, we don't have option other than the femtolaser. Now, someone will say, well, it's only a restricted technology and only in a few machines. I do, yes, I say yes, it is in a few machines. This treating those that they have a hyperopic or mixed astigmatism and they are in need to read without the glasses. That's right. It's limited for 7 years or 10 years, but still it's working. We have it only in the femtolaser, and it's coming into by the smile. These are what we are looking for. We are looking for an options into the, like for example, when we have suction loss, we need to repeat the issues now, which is a great. No, we don't need that. We don't need to repeat the whole session. No, we need to repeat from the point that we aimed.
Yeah.
Like for example, you did the back, and you did the front, and in the front you did 30%, and then you reach, and then suction loss. I need to go back few seconds from that point and finish the story.
To complete, yes.
That's what we are looking for.
Yeah.
So these are, maybe it's a technical terms, and this terminology is a scientific terminology, but we are looking and we are working hardly for that. Yeah.
So this is a shout out to all the companies out there to listen to the doctors, to listen who are listening to their patients and
sure.
know exactly what is required based on their experience day to day with their patients. To listen to these doctors, to modify their machines, come up with new technologies that serve the doctors whom will be serving the patient as.
Exactly.
And happy patients, happy doctor, happy
everyone.
Happy everyone. Thank you very much, Dr. Safwan. I really appreciate this, and definitely we'll have definitely more topics to talk about. And thank you.